Namaskar and good evening, everyone. I welcome you all for today's virtual conference on lung cancer treatment updates 2024. With immense pleasure, I would like to invite Dr. Ajay Sharma, who is medical oncologist, founder and director, Lifeline Cancer Care Hospital, Rohini, Delhi, for the welcome and introductory note and to take the proceedings further. Over to you, sir.
Thank you. So, in continuation to the series about the recent in the lung cancer and updates which we receive every now and then. So, the scientific agenda is for today's meet is it will be Dr. Mahvish for the molecular biomarkers testing in the lung cancer. Dr. Madhur will speak about the overview of the lung cancer, and Dr. Nitin will speak on the exceptional response to osimertinib, EGFR metastatic non-small cell lung cancers. And I'll start the session with the advanced EGFR mutated non-small cell lung cancer and a review of the targeted therapy. So let me share the screen with you people. I hope the screen is visible.
Yes, sir. Just make it full screen.
Is it visible, Mahvish?
Yes, sir. It is visible. You need to make
Okay.
it full screen. Yes, sir.
So let us go through the advanced the non-small cell lung cancer who are EGFR mutated, and we'll review about the targeted therapies. So we all know that lung cancer is one of the most common cancer which we encounter in India as well globally. So it is the second most common cancer diagnosed in males and third cancer in the females. And also, if we come to the mortality, it is number one cause of the cancer related to mortality in males, and it is number two in females. So coming to the stats of India, it is the fourth leading cause of cancer-related death in India, and it is fourth in the overall incidence. So non-small cell lung cancer is the most common type of the lung cancer. The other common cancers we know are the cervix, oral cavity, breast, colorectal, and so on. So, stage-wise, the diagnosed cases we see, majority of the cases we diagnose in stage 4. It is the chunk is approximately coming to 65 to 66%, followed by stage 3, 29, and very few people are in the early the stage 1 and stage 2. So, more than 50% of the stage 4 non-small cell lung cancer have biomarkers. We call them as predictive biomarkers or the prognostic biomarkers. Predictive word itself means indicative of therapeutic efficacy and interaction between the biomarker and therapy, the patient the therapy on patient outcome. Whereas the prognosis are indicative of patient survival independent of the treatment because biomarker is an indicator of the innate tumor aggressiveness. So testing for majority of the genetic mutation, including the PDL1, is recommended in patients with all advanced lung cancer, whether to determine whether they can receive the treatment with the targeted therapies or not. So if we see, these are the various mutations which are seen, and the most common mutations we see, these are the KRAS, the EGFR, the ALK. So these are the three major types in the, especially we do in the adenocarcinoma, and we decide about the targeted therapy. And majority of the patients we see, they are EGFR mutated, and it is more common in the Asian people like women, non-smokers, adenocarcinoma, and the average of the frequency is approximately touching 30%. So the testing methodology is of the mutations in lung adenocarcinoma. It can be like EGFR, ALK, ROS1. The tests which we do are FISH, IHC, and PCR based. So we can see we do ALK and ROS with the FISH, and we do this PDL1 by IHC, and we do EGFR by the PCR based this methods. The EGFR driver mutations in the lung cancer, the most common mutations we see are the exon 18, 19, 20, and 21. And the most common also amongst these, it would be the exon 19 and 21. So, based on the limited number of studies, the prevalence of EGF mutations appears similar across the disease stages. So, as I discussed, the Asians have 30 to 40% prevalence of these mutations, and Caucasians have 10 to 20%. So, prevalence for each stage again is different. So, if we come to the Asian countries, it is really high as compared to the Western countries. In all the stages, we are talking of the mutations. So, mutations are more seen in the Asian population. If EGFR TKIs were available in the resectable setting, a similar proportion of patients may be able to benefit compared to the advanced setting. So these are the NCCN guidelines for the non-small cell lung cancers. And if we see the most recent data that you must do not harbor, these are the like EGFR mutations. The exon 19 and 21 are the most common. And we see that adjuvant TKI therapies are also there for the non-small cell lung cancer in stage 1B and 3A. It's not only that TKIs are used only in the metastatic and advanced lung cancer cases only. So we have a usage of them in the adjuvant therapy also. So these are the mutations which result in constant signaling by the EGFR. We have a wild type and we have mutated genes. So the TKIs, they work on the mutated genes, and we see these are the various mechanisms, and EGFR like L858R sensitivity and 19 deletion is there. So these are the mechanism activated, and we get a response to the therapy. So the current treatment options for the advanced lung cancers, we do first line molecular markers and second line molecular markers. So the initial we do the ROS1 fusion, the ALK, the EGFR mutations, and we are talking of the non-squamous cell cancers, and we do the PDL1 testing also by different methods. So the first line treatment is the crizotinib if it is ALK positive, and if it is EGFR mutation positive, it would be first or second generation this EGFR TKIs. And for the positivity of the PDL1, it is pembrolizumab, and the score we say it should be this more than 1%, 50% of the TPS for the use of the pembrolizumab. And coming to EGFR mutation again, if there is a mutation in like we call it as a T790 mutation, if it is positive, then definitely we don't use other TKIs. It is the osimertinib which has a very good response to these subset of the patients. So other therapies for the ALK fusions are alectinib or ceritinib. And if coming to the immunotherapy, apart from the pembrolizumab, atezolizumab and nivolumab are the other options for the PDL1 positive patients. So osimertinib is a third generation irreversible CNS active TKI selective for both mutated and as I have said for the T790 mutation resistant population also. FLORA is one study in which it was a double-blinded phase 3 study to assess the efficacy of osimertinib versus standard of care as first-line treatment in patients with locally advanced or metastatic EGFR advanced lung cancer. So this is the basic structure of the FLORA study in which the patients with locally advanced or metastatic non-small cell with the inclusion criteria of age more than 80 years, a good performance status with deletion 19 and L858R mutation and stable CNS metastasis. They were allowed in two arms, the osimertinib arm and the EGFR TKI standard of care. So they were followed, and the primary endpoint was the progression-free survival based on the investigator assessment, and the secondary endpoints were the overall response rates, duration of response, and overall survival and the safety of the patient. The characteristic of the treatment arms, these are the baseline characteristics. I will not go into the details. So these are the uh, subset of the study basically. And the response which we saw that osimertinib reduces the risk of progression or death by 54% compared to the standard EGFR TKIs. So in osimertinib arm, the median PFS was 18.9 months, and the other standard of care it was 10.2 months. So various subgroups, we see a consistent benefit of osimertinib over standard EGFR TKIs in this forest graph with respect to the progression-free survival as shown across all the predefined subgroups. So whether it was the age, the race, the sex, the smoking history, the CNS meds, everything favored the osimertinib. And the duration of response was twice as long in patient treated with osimertinib compared to the standard EGFR TKIs. And this is the final FLORA overall survival, and it has a very good hazard ratio. The final overall survival demonstrated a clinically meaningful and statistically significant improvement with osimertinib versus EGFR TKIs. So the summary is adverse event summary are the main side effect which was seen were diarrhea, rash, nail effects, dry skin, paronychia, cough, nausea, and transaminitis. But that frequency was not that much high, so they were well tolerated. And adverse event and safety analysis, if we see the percentage in osimertinib, definitely it was not that too high as compared to the standard of care. So they were comparable, and they were treatable also. So the summary, it is a highly statistically significant, clinically meaningful improvement in PFS and significant improvement in CNS PFS over standard of care. And comparably safety profile is also comparable to the standard of care. So osimertinib is a new standard of care for first-line therapy in patients with mutated EGFR advanced non-small cell lung cancer. Now, coming to the CNS efficacy for osimertinib, the CNS mets occur at a high rates among those harboring the EGFR mutations compared with the wild type EGFR. So, if we see at initial diagnosis, the brain mets, the frequency of brain mets is 19% to 24, and during final follow-up, it is 44% in the EGFR mutations, whereas in the wild type, it is less. It is 11% and 22%. And similar is with the leptomeningeal metastasis also, which is higher in the mutation population as compared to the wild type EGFR. So, osimertinib benefit was consistent in patients with and without CNS metastasis, and few CNS progression events were observed with osimertinib 6%, then standard EGFR TKI, which was 15%. So, similar graph, we see that osimertinib has a much better median CNS PFS, and as compared to the standard of care, and median follow-up in months was 12.4 months with osimertinib and 7 months with the standard of care. Now, osimertinib versus dacometinib. Comparison of osimertinib with dacometinib, definitely the efficacy and the was studied in the Archer and the Flora trial, and it was 18.9 months in the osimertinib, and it is 14.7 months in the Archer study. So it is not statistically significant since the formal comparison of ORR was not statistically significant based on the study's hierarchical testing rules. We are talking of the dacometinib. And whereas in the Flora, first time EGFR has seen PFS to a significant OS benefit. So these are the various articles in which we saw that the dacometinib comparison with the Flora study was definitely superior. Now coming to afatinib, again, if you study osimertinib has a median PFS of 18.9 months, and there were insufficient evidence events to determine OS of afatinib at the time of analysis. So OS survival advantage not seen. It is 27.9 versus 4.5 months. Similar studies with the exon 19 and L858R subgroups, it showed similar OS trends. The safety profile of the drugs, if we see, the Flora has the least side effects: skin rash, paronychia, diarrhea, stomatitis, and the other studies of the Lux and Archer, they have shown, although there were side effects, but not that too high. So studying sequence was also done in the Flora study, like comparator arm, whether first generation TKI, then third generation TKI osimertinib, and crossover. So first line osimertinib had a better results compared to the sequencing staging. So hence dilemma of sequence is also resolved by the Flora study. And the second line treatment eligible for all, predicting T790 mutation. Also, it is not possible to predict who will develop the resistance of T790. And important to start with the drug with greater benefit compared to the TKI. So that's osimertinib. And real world evidence has showed that in clinical practice, approximately 1/3 of patients or fewer receive second line osimertinib. So these are the various again guidelines of EGFR mutation positive non-small cell lung cancer. So preferred is again highlighted is the osimertinib. So conclusion is that for the first time, the evolution of EGFR TKIs, osimertinib translated the PFS into a significant OS benefit, and the median PFS of 18.9 months, with which is significantly higher than the first and second generation EGFR TKIs. And osimertinib has shown efficacy in patients with CNS metastasis. Fewer CNS progression events were observed compared with the standard of care, and less adverse event were seen, and a better safety profile was there. So osimertinib is the new standard of care for the first line therapy in patients with advanced non-small cell lung cancer who are EGFR mutated. Thank you. So with this, I close my talk for the today, and hand over to you.
Thank you, sir. Thank you for your wonderful talk. And as we move forward, I would like to invite for the next talk, Dr. Mahvesh, who is Resident Medical Officer, AS Cancer Hospital, Rohini, Delhi, for the talk on molecular biomarker testing in lung cancer. Over to you, sir.
Good evening, everybody. This is Dr. Mahvesh.
Ma'am, your voice is
Is the screen visible?
Yes, ma'am.
Yes, screen.
Support team, can you help?
Ma'am, if you log in with to another device, please log out from one device.
Yes, doctor, you can proceed.
Good evening, everybody. This is Dr. Mahvesh. Hello. Am I audible?
Yes, ma'am. You're audible and your screen is visible.
Yeah. Just before we heard Dr. Ajay Sharma, sir, he gave us a brief introduction regarding the lung cancer and the modern treatment that is right now going on. So before starting the treatment for any lung cancer or any cancer, we go for the molecular biomarker testing or some other tests are also, but my main focus right now is for the biomolecular testing in the lung cancer. What actually this test helps us, it's actually for the mutation, addition or deletion, or we can say if any rearrangement occurs in any point in the DNA, it helps us to visualize that thing. It also helps us to look other key markers like different levels of protein or amount of tumor DNA in the blood. We know that there are different types of the lung cancer, so every tumor has different makeup, and every tumor has its own DNA and specific level of proteins. So basic on that, we can see there are different biomarker testing for non-small cell lung cancer or adenocarcinoma. Basically, we will see today that there are so many biomarkers, but we can every biomarker we can give for adenocarcinoma, but there are some selective markers that we give for non-small cell lung cancer. So there are different tests that we see, and based on that, we can select the patient for either target therapy or chemotherapy. It will be totally decidable by the by looking at the marker. And for example, we have RNA sequence paneling. It detects the fusion abnormalities, and it's more sensitive towards the ALK, ROS1, RET gene, and NT-KR gene. We have FISH or ICH, which detects the ALK or ROS1. In non-small cell lung cancer, we can go for single gene reflex testing or multiple gene reflex testing. Multiple gene reflex testing we mainly do by NGS, that is next gen sequencing technique, which helps us to give the genomic alterations at that level. So few biomarkers that I mainly focus on, which are routinely used for adenocarcinomas, and can selectively we can give for non-small cell lung cancer. For example, EGFR, BRAF, or ALK, MET exon 14 skipping, PDL1 expressions. And in PDL1 expressions, we use different antibodies to check the PDL1 levels. In ctDNA testing, that is for the circulatory tumor DNA testing, it has a potential to be applied across all stages of the non-small cell lung cancer. And throughout the treatment pathway, we can decide the treatment and the diagnosis for different patients on the basis of selection. In this, we can see that the lung cancer has been almost about the 8% of the global total number in new cases in 2020, but since 2020 it has increased. Right now it's more than 20%. And we can see by new sequence generation testing, we can easily give more emphasis on the lung cancer, because it gives us detailed information of different mutations. So, if we talk about the KRAS mutation, it's mutually and exclusively with EGFR and ALK mutations, and it accounts for nearly 30% of the lung adenocarcinoma. Most of these we see arise in codon 12 and 16, and if we present with G12C variant that is found in 13% of the patients, it predicts the poor prognosis then. And if we talk about the BRAF mutation, more than 50% of the BRAF mutation we see in the smokers. Usually, most commonly, we see this mutation in the smokers. And what is that advantage of the NGS or the PCR? One study shows that 48.6% of EGFR exons are mutated identically via NGS. and by PCR we missed them. We can go for some other rearrangement testing, for example, ROS1. We can do IHC screening or broad molecular profiling. We can do FISH, or we can do a PCR, but on lower level. So also we can see that in NSCLC, that is non-small cell lung cancer, it has evolved from a single gene to the multiple gene testing, that is multiplex testing, that currently we see that it has evolved. Hello, am I audible? Hello.
Yeah, ma'am, you are.
Yes, ma'am, you're audible.
Oh, ma'am, hello.
Yes.
Okay, so I can proceed from this point that DNA sequencing or NGS or PCR, it detects the insertions and aberrations in the EGFR, KRAS, BRAF, HER2/neu, single gene or full NGS panel. But usually it saves our time to look for the more it looks for more exponential level. For example, in EGFR, we can go for the multiple tests, but we prefer NGS test because it's a broad profiling and the key component for the improvement in case of the patients with non-small cell lung cancer. Same is the case that studies have been showing that it has increased since years, and now globally it has also increased in terms of the case wise or in terms of the area wise. Like lung cancer right now has a 72 almost 72% increased risk since 2020. Can you change the slide? Hello. Yeah. So 50% of the patients with advanced non-small cell lung cancer has driven the mutation targetably with FDA approved agents. Or on the clinical trial basis, we can see that there are several new mutations, and for them we have accordingly developed the treatment. KRAS, we can see for the 25% of the patients or the population, and some ALK has a 7%, EGFR has 17%, and there are some unknown driven factors which are not yet detectable, and it has 31%. And we can see there's a different treatments, like now that we go on for the different biomolecular detectable type of cancers. For example, in the BRAF, we go Girafinib, and for our RET fusion, we go Paralastinib, and for NTRK, we go Entristab. So basically, it depends. The treatment depends on the type of mutation we get on the genomic level. Next. The importance of biomolecular testing in non-small lung cancer has shown that with identifiable actionable mutations who receive the appropriate targeted therapy have improved outcomes. For example, this graph also shows that it has increased by targeted therapy, and when we were having no target therapy at that time, we don't have this much good prognosis. Change, please. Yeah, there are several biomarkers which I already discussed, and there are different cancers of the lung in which we can see, for example, EGFR mutation is seen in non-small cell lung cancer or adenosarcoma, or adenocarcinoma, or we can see according to the latest guidelines, there is an amplification of the both and non-small cell lung cancer with the KRAS mutation, and they indicate the poor prognosis in the patient with KRAS mutation and are unlikely benefit for the further molecular testing. But if we go for the data, we can see that now due to additional of the biomarkers, they are tested based on the data that were not available previously. So it also has a good benefit for us that routinely testing for the molecular aberration is recommended for all adenocarcinomas, as I discussed earlier. But yeah, for squamous non-cell carcinoma, we have only selective this mutations. Next. We have different methods of testing at the tissue level. For example, if we go for DNA sequencing or PCR, it helps us to detect the point mutation for patients. Uh, and if we go for RNA sequencing, it detects fusion abnormalities. And most likely it is sensitive for ROS1, ALK gene, RET gene, and NTRX gene. And if we go for FISH or IHC, then it detects highly specialized or which are faster tumors. It detects that mutation. For example, in ALK and ROS1, it's an easy test and the fast. It gives us quick guidelines for the treatment because it's that much sensitive. Next. Next, ma'am. So tissue journey biopsy to analysis, we first get a small tissue excision, either a liquid biopsy based or the cytology based, and or the fine needle aspiration, in which the cells are taken from the body surfaces or either from the urine, ascitic fluid, sputum, or CSF. Then we or go for the liquid biopsies where we can take the serum or the blood. Then after this we can make the blocks, either non-cell block side or the PP FFP block side, and in this we can get the extraction of the DNA or RNA or protein, depends on the what type of sample is, and then we analyze on the basis of PCR or cancer gene panels. We can give RNA sequencing if we take the RNA sample, and we can finally go on the data analysis. So it's the basic level for the biopsy method can be given by the surgeon or pathologist or clinicians from the patients, and to the laboratories or pathologists at the analysis based level. So for that we make the blocks, and according to that we can get the information for the type of cytology and the tissue. Next. So biopsy, it establishes diagnosis and determine the subtype, histological subtype or biomarker testing. For example, if the cytological subtype is squamous or non-squamous, for biomarker testing, we have primary tumors and some metastatic tumors that has originated from other side. We have bone biopsy, due to which we can see the degradation in DNA level. In liquid biopsies, it's another option where we can see cell-free DNA in the plasma, and we have these all tests, ALK, ROS1, BRAF, RET, MET, exon 14, and they are all for the non-squamous, non-small cell lung cancer. We use the broad NGS testing to detect most mutations using least amount of tissue. And for the squamous type, that is usually we considered in case of young individuals or we who have never smoked or are light smokers. For them, we go for the mixed cytology. Next. Yeah, I already discussed this with you that based on the cDNA, we can entirely replace the tissue biopsy with the liquid biopsy and to support the treatment, the selection of the patients. And Dr. Ajay sir has already given Dr. Ajay Sharma sir has already given this introduction to us. So can we conclude this because it's repeating? For diagnosis and treatment, Ajay sir has already discussed this with us. So this was the part of biomolecular testing that I gave the brief introduction, and so the next Dr. Madhur, I guess he will continue from here.
Thank you, ma'am. Thank you so much for the nice presentation. And as we move forward, I would like to invite Dr. Nishant. Dr. Nishant is Resident Medical Officer at AS Lifeline Cancer Care Hospital, Rohini, Delhi, for his talk on exceptional response to osimertinib EGFR metastatic non-small cell lung cancer. Over to you, sir.
Good evening to all my respected sir and ma'am.
Hello.
Yes,
Yes, Dr.
ma'am. I'm trying to share my screen, ma'am.
Yeah, sure.
Ma'am, now it is visual.
No, sir, your screen is not visible. Yes, it is visible now.
Oh. Hello, ma'am. Now it is visible.
Yes, it is visible. Just make it full screen, sir.
Once. Ma'am, now it is okay.
It's visible. You can make it full screen, sir.
Ma'am, there is no option for full screen, ma'am. I don't know.
Okay.
Ma'am,
So there
can I
is-
start from?
Sure. Fine. Start, sir.
Today my topic is exceptional response to osimertinib, which is epidermal growth factor receptor mutation, and that is metastatic non-small cell lung cancer. There are some cases in which there are observed data in October 2020. There was a patient who have a symptom like coughing and progressive breathlessness and severe backache. And even he could not walk without any support from since 10 days. And he have giddiness since 5 to 6 days and weight loss of 5 kg in last 1 month. And his personal history is non-smoker. And on PET scan, a mass lesion in the right upper lobe with hilar nodes was seen with multiple bone metastasis. And biopsy and molecular analysis. In biopsy, the histopathology lab reveals the adenocarcinoma in which TTF1 is positive and APSIN A positive and negative for P40. And on molecular analysis, EGFR exon 19 mutation is positive and KRAS weight BRAF is negative and MET exon 14 is negative, ALK is negative, ROS1 is negative, and HER1 also is negative. Sorry, HER2 is also negative. And PDL1 was also negative.
निशान से पहले तो बोल दो ना मुझे।
On MRI, the multiple ring enhancing lesion in cerebellum and cerebral hemisphere with significant perilesional vasogenic oedema are seen on the MRI of the brain. And thereafter, we come at final diagnosis. There is stage 4 NSCL adenocarcinoma with exon 19 dealt with bone and brain metastasis. Now, there is management part of this case and in which local radiation therapy for metastasis and add on with EGFR TKIs to target exon 19 del. Here are some treatment data in which managing a patient with EGFRM and a non-small cell lung carcinoma in which first, second, and third generation of tyrokinase inhibitor are seen. Here are some data in which Gefitinib was in median PFS experimental. It was shown to 9.5. And Erlotinib, it is also optimal and it is seen to 13.1. And Aftinib is also 11.0. And Decamitinib is 14.7. And Osimertinib is 18.9. There are first generation TKIs, second generation, and third generation. The color shows the data over here. In degree of CNS penetration of osimertinib, the osimertinib demonstrated higher mouse brain concentration than other tyrokinase inhibitor. There is a dose and plasma Cmax, brain Cmax, and brain plasma Cmax ratio, in which there is 3 drugs: osimertinib, gefitinib, and afatinib, in which there is dose with mg per kg. Osimertinib is 25, which shows plasma Cmax 0.82 and brain Cmax 2.78, and brain plasma Cmax ratio shows 3.41. And like in this way, Gefitinib also shows with subsequent dose like 6.25 mg per kg, which shows plasma Cmax 0.82 and brain Cmax 0.17, and brain plasma Cmax ratio shows 0.21. And Aftinib also with dosage 7.5 mg per kg, which shows plasma Cmax 0.14 and brain Cmax, it is BLQ, and brain plasma Cmax ratio is more than, less than 0.36. There is a degree of CNS penetration of osimertinib in which individual regional distribution are seen on the scan. The regional distribution binding of osimertinib on PET parametric image showing total volume of distribution. There are several comparison of PET1, PET2, and PET3 with another patient, PET1, PET2, and PET3. There is a comparison between patient 1 and patient 2. And managing a patient with epidermal growth factor receptor mutation with NSCLC and CNS metastasis, there is a which is newly diagnosed EGFR positive, and B which is progression on first or second generation of EGFR with tyrokinase inhibitor. Here shows brain metastasis. If there is, if it is symptomatic, then there is local therapy with surgery and SRS. If there is no any symptom, then we give osimertinib. And in B, progression on first or second generation with EGFR, like a brain PD with Parkinson's disease, in which if symptomatic, then there is also local therapy and surgery. And if no, then CNS Parkinson's disease and CNS systemic Parkinson's disease. And there are some receptor data in which T790 M1 is positive for CNS PD. In which osimertinib is lastly considerable as a drug for effectiveness, and T790M in which SRS and WRT, which continues the tyrokinase inhibitor. and that act on the cancer cell. And in CNS with systematic PD, there is T70M positive, and another one is T790M negative. And there is osimertinib, again the drug of choice or effective drug in lung cancer we give. And if T790 is negative, then SRS and chemotherapy will be given. Here is a FLORA and a trial and brain outcomes. Here are some data we see over the screen. Here are also EGFR in which there are comparison with drug like its response by BICR and like month with HR. Like there are 3 drugs in EGFR TKI group. Aftinib, Dacomitinib, and osimertinib. The study shows Aftinib. The study of Aftinib shows Lux Lung 3/61, which is versus of chemotherapy, and Lux Lung 7, which is versus of Jeftinib. And patient population, it based on baseline asymptomatic brain metastasis, in which N is equal to 81, and the baseline asymptomatic brain metastasis, in which N is equal to 51. And response is systematic for Aftinib, and lung 3 and lung 6 is noted here. And median of CNS PFS by BICR, it shows 8.2 versus 5.2 value of the data. And just like Aftinib, there is also Dacomitinib study and patient population, and osimertinib. We have to focus on osimertinib, in which the study shows FLORA, which is versus of Jeftinib or erlotinib. And it on patient population, it shows baseline asymptomatic CNS metastasis, and a baseline asymptomatic CNS metastasis, which is determined by neurological BICR. And in response, there is a systematic and as well as a response on CNS also. And response rate by BICR, the data is not reported till now. But 66 versus 43 is shown here. And median CNS PFS by BICR shows 15.2, which is investigator assessment, and in which NR versus 13.9 with the ratio. Treatment given in the case study of in year 2020 in month of November for bone metastasis, in which palliative radiotherapy to spine for back ache, which is treated with zoledronic acid, which is bisphosphonate. And for brain metastasis, patient denied to take brain RT and wanted to see later. Start on first line TKIs. Osimertinib dosage is 80 mg per day. Case study shows on PET scan in 2021, in year 2021, and in month of March. Right upper lobe lesion enhancing the right upper lobe bronchus. Actually, this is another case in which PET scan shows the changes are seen in the we can compare the changes, and reduction in the right hilar and paratracheal nodes. We can also see the changes in millimeter. Effectiveness of a tyrokinase inhibitor in brain metastasis. The table shows the efficacy of osimertinib and first generation EGFR TKIs in patient with BMS. The efficacy parameter is here, and there is a drug osimertinib, erlotinib, or Jeftinib, or osimertinib, or erlotinib and Jeftinib. There is actually comparison with CNS ORR and CNS DCRR. In osimertinib, it shows 66 and 90 of data, and in median CNS, it is not considered. Erlotinib shows 43, and like that, all data is mentioned here. We can see the data on the screen. On follow-up MRI, the contrast shows the higher bone masses reduction and the growth of the growth or reduction of the cancerous cell. And follow-up MRI, which shows completion resolution of brain lesion or MRI of brain. There is no additional intervention was needed. The real-world evidence report on osimertinib and brain metastasis. There is also a case, a 53-year-old patient relapsed while being on chemotherapy for second, third day. Subsequent scan revealed pretracheal nodal hypermetabolism, and on a repeat brain MRI, she was found to have multiple brain metastases, including 3.1 centimeter inferior Vermeer metastasis with surrounding edema. Osimertinib was started with initial dose of 80 mg daily. Patient complaints of ataxia. The side effect was shown like ataxia, which worsened significantly in the following days and was scheduled for craniotomy and tumor resection for the following next week. The case report on osimertinib, there is complete remission of multiple brain metastasis in patient with epidermal growth factor receptor mutation, NSCLC, treated with first-line osimertinib without radiotherapy. The effect of osimertinib here, so the effect of osimertinib without radiotherapy, and the osimertinib demonstrate efficacy against a stable of asymptomatic CNS and metastasis of EGFR in which mutation is positive, and non-small cell lung cancer in phase 2 and 3 clinical trial that allowed prior to CNS radiotherapy. And in left upper lobe mass and multiple bilateral lung metastasis was shown, and a total of more than 20 asymptomatic multiple brain metastasis with multiple diameter of 12 mm were diagnosed simultaneously. And after 5 weeks, the multiple brain metastasis disappeared completely together with the response in the lung lesion. This case demonstrated the first-line treatment with osimertinib without radiotherapy could even complete the remission of multiple brain metastasis comprising as many as 20 lesions of EGFR mutated and NSCLC without radiation therapy, like as I told earlier. Another study demonstrated by efficacy in CNS metastasis. It is on neuro-oncology, in which osimertinib, it is advanced EGFR. We discussed earlier about that, and it is also used in adenocarcinoma with asymptomatic and symptomatic both type of patient. In background, osimertinib, it is a selective for both epidermal and tyrokinase inhibitor for both, and while intracranial activity of osimertinib, it is documented in larger trial, like a prospective study focusing exclusively on patient with asymptomatic brain metastasis, and it has been reported significantly. And in phase 2 open level 3 arm prospective and proof of concept pilot study, 48 patients with metastatic EGFR mutated lung adenocarcinoma was received with osimertinib 80 mg initial dose, and patients were either treatment with arm 1 and previously treated with EGFR TKIs, which shows a negative arm for C is equal to 10. In case of isolated intracranial progression, we see the osimertinib dose was escalated with 160 mg. With like its plasma Cmax and all of that. The primary endpoint was intracranial progression with a free survival, and this study registered at a clinical trial, and the result is the IORR were 84.2%. and 66.7% and 50%, and IDCR were 94.7%, 94.4%, and 80% in arm A, B, and C respectively. The median IPFS was 11.8 months. And like this, we on the conclusion, we find osimertinib demonstrated as a higher efficacy on brain metastasis, and all trial arms displayed a significant decrease in the number and diameter of target lesion. There is a PET scan of completion of cases in November 2021 and in April 2022. There is almost complete response is seen here. And finally, the discussion and key point and food for thought. The radiotherapy for brain are not needed. Still, patient had completed resolution of brain metastasis, almost complete resolution of primary disease and nodes. There is no any adverse event were reported in this patient, and patient remained progression free even after 19 months after initiating osimertinib. He's asymptomatic and fully active. Goes for morning walk and yoga session like normal people can do. And there is we saw the excellent response of osimertinib or in such a tumor in which tumor are different, and we have also biomarker to predict such excellent response and compare the response of osimertinib with PET scan and the efficacy of the drug of osimertinib. Thank you. Ending my session with this topic now. Thank you, ma'am. Thank you, sir.
Thank you. Next, I would like to invite Dr. Madhur. He is a resident oncologist at BMMC and Safdarjung Hospital, Delhi. It's over to you, sir.
Dr. Nishant, can you stop
Can
sharing
you,
your
sir,
screen?
please stop your...
Hello. Hello, am I
Dr.
audible?
Yes, sir, you are
Yes,
audible. Dr. Nishant, please stop sharing it. Yeah, thank you. Yeah, Dr. Madhu.
Good evening, everyone. First of all, I would like to thank Dr. Ajay Sharma sir for giving me this opportunity to speak in front of you all. Please share my slide, please.
Yes, sir.
So mostly I will be speaking overall about the lung cancers. Next slide, please. The burden of lung cancer in India, according to the Globocon 2020. So lung cancer is about 5.5% about the total population of the lung cancers, as we all know, and it's the worst prognosis. Next slide, please. It's the second most common. Next slide. So optimal staging is required to decide best treatment options in early lung cancers. So we need to do the TNM staging. According to the TNM staging, our treatment is done. Next slide. Investigative tools for staging: bronchoscopy, CECT chest, PET-CT, EBUS, EUS, videostanoscopy, and MRI brain. Slide. CECT versus PET-CT for staging in stage 3 non-small cell lung cancer. Lymph node more than 10 mm along short axis is the predictor for malignancy. CT scan alone has limited role due to low sensitivity, 55%, but if we do the PET-CT, it is approximately 85 to 95%. And it's the overall sensitivity of 80 to 90%. Next slide. So risk factor of occult 2 and 2 not always detected by imaging. So Basically, we need to see the central tumor, size of tumor, higher SUV on PET. Next slide. Next slide, please. Media channel staging, less invasive, EUS, EBUS biopsy, and invasive media steinoscopy, conventional VAMLA and TAMLA VATS. Next. Media channel staging, recommended techniques are EBUS and EUS if clinical suspicion of nodular tooth involvement remains high even after a negative EBUS and EUS, then surgical staging with median endoscopy is recommended. Next slide. When is invasive media standard staging indicated? Centrally located tumors, yes. Tumor size more than 3 centimeter. Extensive infiltration of the media standard with no evidence of extra thoracic disease. Positive N1, yes. Bulky N2 on CT, no need for invasive confirmations. Discrete N2, yes, regardless of PET CT result. Normal media standard on CT, but positive on PET, yes. Negative PET, no. Media channel staging algorithm protocol. So this is basically a PET CT with intrathoracic lung cancer with or without enlarged lymph nodes. So we have the two different modules. So in the first media channel lymph node negative. So the end result will be surgical or a radical radiotherapy. For media channel lymph node positive, so we need to do the surgical staging and multinodality treatment. Next slide. We can skip this slide. Non-invasive and invasive staging modality. So we have the CTC and PET CT, EBUS, EUS, and EBUS plus EUS, EBUS plus EUS plus MED, VATS. So amongst all, VATS is the most VATS is the basically the best we can do. Evolution of therapy in lung cancer. Non-small cell lung cancer was considered a single disease, but distinct subtypes characteristic identified. Non-small cell lung cancer, sorry, subtype characteristics have clinically related for treatment planning for diagnosis. So PD-L1 expression level is more than 1 to 49% and more than 50%. Next. So this is the advances in management of non-small cell lung cancer has improved survivals. Lung cancer specific survival improved from 26% amongst men with non-small cell lung cancer that were diagnosed from 2001 to 35%. So it has been improved. Reduction in incidence along with treatment advances, particularly approvals and use of targeted therapies. Next. Advances in treatment of non-small cell lung cancer, early and late stage targeted immunotherapy. So from 2006 to 2020, so we were doing targeted therapies historical, but now we are doing targeted therapy, IC1 histological selection, and then ICL PD-L1 selected. So capmatinib for metastatic positive non-small cell in May, and atezolizumab for non-small cell more than 50%. A significant increase in approvals for both targeted as well as immunotherapy in non-small cell lung cancer can be seen. Next slide. Molecular targets in non-small cell lung cancers. All patients with non-small cell lung cancer should undergo molecular proliferation to identify targetable alterations. The increase in the need for molecular testing in non-small cell lung cancer. Molecular testing should be standard of care in non-small cell lung cancer. So there are 7 molecular alterations: EGFR, ALK, ROS1, as we know, NTRK, MET, exon 14 are RET. Next slide. Current guidelines on neoadjuvant and adjuvant chemotherapy depend on the disease stage and findings during surgery. So we have stage 1, no lymph nodes, stage 1B and 2A, no lymph node seen, and stage 2B, no lymph node is seen, and new for the stage 3A and 3B, new adjuvant chemotherapy or sequential chemotherapy plus radiotherapy we can do. Next. Finding at surgery and surgical resection margins affect adjuvant treatment decisions. Resection margin as well as pathological site affect adjuvant treatment decisions. So, findings at surgery, if we have stage 1, so we need to do re-resection or RT plus minus chemotherapy. But for the stage 3A and 3B, so we need to CRT sequential concurrent or CRT concurrent. Next. After initial treatment, more than half of the patient with resectable non-small cell lung cancer experience recurrence within 5 years. Overall outcomes still need to be improved for the patient. Next. So this is basically a graph regarding the latest ESMO guidelines recommended for adjuvant chemotherapy. However, since the guidelines were published, stage tumor 1B tumor more than 5 cm has been classified stage 2. Adjuvant chemotherapy may remain an option for patients with 1B disease who have high risk due to factors other than the tumor size. Next. LACE meta-analysis OS benefit from prospective cisplatin in early stage non-small cell lung cancer. Pooled analysis for 5 trials evaluating adjuvant cisplatin-based chemotherapy. Chemotherapy lead to improved OS HR 0.89, absolute benefit from 3.9% and 5.4% at the end of 3rd and 5th year respectively. So this is basically a randomization control studies. Next slide. How well the new adjuvant chemo work? About the same as adjuvant. For stage 1B to 3rd A, new adjuvant chemo, so HR is 0.87 and adjuvant chemo HR is 0.89. So basically it's a prospective and retrospective case studies. So prospective it's a forward studies, and retrospective is basically we can go earlier in these studies. Next. Improved survival in resected EGFR non-small cell lung cancer. Our targeted therapy is now moving to early stages, ADAURA trials. Improved DFS seen in osimertinib in resected EGFR and non-small cell lung cancer with introduction of EGFR TKI DFS. DFS is improved from 44% to placebo to 90% in EGFR TKI1 arm at 24 months. It is now possible to further improve survival in completely resectable stage after the surgery. Next. Atezolizumab showed an improvement in DFS as well as OS in adjuvant settings. Atezolizumab showed an improvement in survival. Am I audible now?
Yes, sir.
So,
Okay. Atezolizumab showed an improvement in survival in adjuvant settings in patients who had PDL1 more than 1%, and such therapy will be improve survival rates in non-small cell lung cancer. Next slide. Lung cancer radiation in 2022. Advanced technologies have led to safer treatment, reduced dose to heart with lower rates of grade more than 3 pneumonitis, increasing dose to heart associated with higher risk of death in stage 3 non-small cell lung cancer. This is a dose distribution diagram on 3D CRT and IMR. Right? Semantics for radiation, what's relevant to the pulmonologist? SBRT, it is important to differentiate between stereostatic body radiation therapy versus conventional. So SBRT is high dose per fraction. So it is approximately 1 to 5 fraction within the 3D target localization. SBRT is usually in early stage lung cancer, but due to concern for toxicity, not used for large tumors more than 5 centimeters with nodes. Next slide. Next slide. Next slide, please. Lung cancer radiation in 2022. So we have 4D CT planning, image guided radiation therapy, adaptive radiation, and end result. So here are the diagrams about the 4D CT X simulation, and you can easily see the mass in the lungs. IGRT treatment delivery. Next slide. Contemporary RT techniques in stage 3 and non-small cell lung cancer long-term OS results from RTOG 0617. So it is basically stage 3, 5 years OS is approximately 32%. Now even better results when immunotherapy is added to CRT. So it is a brief about adding the immunotherapy on the 2 cards CRT. Stage 3 non-small cell lung cancer is potentially curable disease. Next slide. Earlier it was having a worse prognosis, so now it is we can treat. Chemotherapy with or without radiotherapy is standard for care after complete release. Patient with stage 3 non-small cell lung cancer. Stage 3A, stage 1A is observation. Stage 2 is multidisciplinary team consult, and stage 2 is chemotherapy. Stage 3 is chemotherapy plus sequential chemotherapy plus radiotherapy. Next slide. Checkpoint inhibition is moving to early stages unresectable stage 3. So randomized double-blind placebo-controlled phase 3 trials of consolidation. Durvalumab is unresectable non-small cell lung cancer. Okay. Durvalumab demonstrated 42.9% OS at 5 years. In comparison to historical OS is unresectable 3 non-small cell lung cancer at 5 years in 15 to 25%. Next slide. Emerging treatment paradigms in non-small cell lung cancer. It is targeted therapy and immunotherapy. Next slide. Targeted therapies are improving outcomes in advanced non-small cell lung cancer. With chemotherapy, the median PFS is 5 to 7 months. With EGFR TKI, this is increased to 18.9 months. And with ALK inhibitors, it is 34.8 months. Next slide. Other emerging molecular targets in advanced non-small cell lung cancer. Newer targeted agents are being identified. This will help to increase the survival of the subsequent patient. So MET exon 14 is crizotinib, and RET arrangement is cabozantinib. NTRK rearrangement is larotrectinib, and HER2 mutations is trastuzumab. Next slide. Survival outcomes with targeted therapy in advanced non-small cell lung cancer. With recent advances, survival rates are improving compared to chemotherapy alone. So it is historical and targeted, as I already discussed in the last few of the slides. Next slide. Immunotherapy in non-small cell lung cancer, immune checkpoint inhibitors. So it is CTLA-4 blockade and PD-1 and PD-L1 blockade, using body down immune cell to fight cancer cells. Next slide. Approvals for ICI over time. So from 2015 to 2021, atezolizumab with non-small cell lung cancer, nivolumab, and with PD-L1 TC more than 1%. Next slide. Survival outcomes with the ICI, historical immunotherapy based histological, any PD-L1, immunotherapy based PD-L1, any histology. I have already discussed this. As you can see, checkpoint inhibitors have improved survival in advanced non-small cell lung cancer, immunotherapy in stage 4 non-small cell lung cancer. Next slide. Basically Patient with pembrolizumab compared to chemotherapy with PDL1 TPS more than 50%, almost 32% patients are alive at least 5 years with the use of IO in metastatic non-small cell lung cancer. Next slide. Checkpoint inhibition in moving to early stages 1 to 3 in resectable non-small cell lung cancer as adjuvant or neoadjuvant chemotherapies. Multiple ongoing trials in adjuvant settings with ISI, Pearls, Keynote 0.1. So BR31 is durvalumab, Envenil is novolumab, IM Power 0101 is etolazolizumab. Next slide. What is new in non-small cell lung cancer? It is the approved therapy in breast cancer. It is coming for upcoming in non-small cell lung cancer. It is basically a design is antibody drug conjugate. So according to this ADC binds to antigen, and then internalization with endocytosis, degradation of ADC in lysosomes, release of payload and drug action, apoptosis of targeted cells. Next slide. CAR T cell therapy, a new era in cancer immunotherapy. So we take the body's own cell and next slide. The management landscape is fast changing in non-small cell lung cancer. Newer therapies have huge potential to prove survival, especially when detected in early stages. Pulmonologists will play a huge role in early diagnosis and crucial involvement in non-small cell lung cancer tumor boards. Next slide. Over to you. Thank you, everyone.
Hello.
Thank you everyone for joining today's webinar. We'll meet again. Good night, everyone. Thanks, Manisha and Uday, for supporting.
Thank you, everyone. Thank you.
Thank you, everyone.